Good afternoon, everyone. Welcome. I am Shilpa Sood. I'm the moderator for today's session. I am a pediatric gastroenterologist and a transplant hepatologist at Boston Children's Health Physicians, New York Medical College. I have Dr. Jonathan Fuchs here with me, who is also a pediatric transplant hepatologist, my co-chair from Yale School of Medicine. Today, we are discussing CF hepatobiliary involvement, and with an emphasis on the spectrum of liver injury, nutrition and liver disease, liver fibrosis, and diagnostic imaging. So the way the session is going to be, we have about 4 speakers. After every speaker, we'll have about 5 minutes for questions. If you have additional questions, we can try to go back to the questions at the end of the session. I'm going to hand the mic over to Dr. Jonathan Fuchs to introduce our first speaker.
Thank you. Our first speaker is Dr. Michael Narkowitz, who's a professor of pediatrics at the University of Colorado School of Medicine. His teaching and research has spanned infectious hepatitis, liver transplantation, and now is best known for his tremendous work that has helped us better understand CF and liver disease. He's the PI for the CF Liver Disease Network and also the liver PI for the PROMISE study. He's had funding and has funding from the NIH as well as the CF Foundation. He's also very much involved with education. He's my mentor at Digest. He's the mentor for many physicians that have been lucky enough to have met him, and I'll let him begin with his talk.
See what you think of the talk first. Thank you, Yanni. So I've been charged to talk about liver enzyme abnormalities in CF and deciphering the causes. There's not that much known about it, so we're going to leave here with sort of some challenges, but I will try to elucidate some key points. I do have disclosures, and I do want to call one out. I consult for Vertex, and my area of consultation is actually on liver injury, not only in modulators, but other drug-induced areas. So data I discuss around what's known will include publicly available data. Today, we're going to start at the basics because there are many hepatologists here, but there are also individuals who care for CF and may not know that much about liver injury. And so we're going to describe the value of liver tests in CF and understand what do they mean and what's the difference between liver enzymes and liver synthetic function. And if you leave here with one thing, I want you to leave never using the term liver function tests again. To understand some of the abnormalities we see with the therapies that are being introduced, it's important to go backwards and understand the prevalence of liver enzyme abnormalities before any of the therapies that currently exist. And that really sets the stage because CF is very different than a lot of other disorders. So I'm going to do that. I'm going to present the schema to you about how I think we should think about drug-induced liver injury or liver disease in CF. And then I'm going to provide, if I can go back, I'm going to provide some data on potential approach to the evaluation. So I like to start with a case because that's what we do. We take care of patients. So this is a real case. It's a 12-year-old female who I cared for. At the time, she was F508del homozygous, had baseline normal liver blood tests, starts on ETI, and 1 month later, these are her liver enzymes, 400 to 500 with a high GGT, normal bilirubin. So what did we do? We did what everybody did back then. We stopped their ETI. 1 week later, liver enzymes are almost normal again. So we waited a little bit. 3 months later, these are enzymes. So you can see they're mildly abnormal, but they're in range. Restarted ETI at a lower dose. 2 weeks later, her enzymes were somewhat up, but we continued. But then 5 months later, she presents perfectly well, no illness, with AST and ALT in the 350s again, and the bilirubin is up a little bit. Total is up at 0.9. We stop again. There's a slower decline, but better. So we wait a little longer. 5 months later, we restarted. Actually, 2 months later, we restarted. And after 3 months, these are her liver enzymes, much higher. we stopped. Okay. So I told you this already. Let's talk about the liver blood tests that we measure. So AST and ALT, you can see their names here. I'm not going to pronounce them for you, although I could, are cellular enzymes found within the hepatocyte. What's important is they're not only found within the hepatocyte, but they are found in other tissues. AST particularly, very highly expressed in muscle, in red blood cells, and then some other tissues, even the kidney. ALT is less expressed in other tissues, but still expressed in muscle. And so it's been felt to be more specific for the liver. And differences between AST and ALT can sometimes tell you what part of the liver cell is being injured. AST is found both in mitochondrial and cytosolic fractions. So, for example, in alcoholic liver disease, AST is much higher than ALT because alcohol affects the mitochondria. So as you think about that, you should think, well, elevations may indicate hepatocyte injury, but it could also be just poor clearance of the enzyme, which has been described, or a non-liver source. And so you want to keep that in your mind. What about GGT for the pediatric colleagues and alkaline phosphatase for my adult colleagues? These are enzymes that are found in the biliary epithelium. GGT is primarily in bile ducts. It's in the intestine and kidney, and it can be induced by medications. It's well known that when an individual's on phenobarb for seizures or other reasons, their GGT will climb, and that's because they are upregulating rough endoplasmic reticulum in the biliary hepatocytes where it's made. Alkaline phosphatase, which has traditionally been the biliary marker for adults in liver disease, is also made in the liver and in the biliary epithelium, but it's also made in the bone, and so it's less useful in children and adolescents due to bone growth. Elevations may suggest cholestasis or biliary injury. And then there are tests of function. These are very rarely abnormal in CF, but when they are, you should pay attention. Bilirubin, unconjugated or indirect elevations are very common on modulator therapy right now for a variety of reasons, including transporter inhibition, and generally not indicative of significant injury. But if you have direct or conjugated, you need to pay attention. People say, well, albumin's normal, their liver function's normal. That's not true. It's a very long half-life protein, so don't look at that. And acute reductions, it's not liver. You're losing it somewhere. The best test to know is PT or INR. When that's abnormal, you should pay attention. But remember, our patients are at risk for fat-soluble vitamin deficiency, and vitamin K supplementation or replacement should be done before you think that it's abnormal because of liver injury. All right, let's go to the next question. How common are liver enzyme abnormalities in people with CF? They are very common. So this is a study that was performed by our group in Colorado, and we looked at all of our newborn screened individuals. And remember, you probably don't know, Colorado started newborn screening in 1982. So we established a database and followed this. These individuals, we looked at their annual visit and well visit values and looked at their elevations. And this is a simple graph of ALT values. But what I point out is these are well CF individuals, not sick. You can see that there's a large frequency of elevated liver enzymes in individuals over time. And if you look on the left-hand side, the younger children have higher and more significant elevations. And I'd refer you to the BEGIN study, which has also found very similar data when they've looked at the young children. And persistent abnormalities, defined as more than 6 months, are also common. So any elevation that's persistent occurs in 20% of individuals by 10 years of age, and any abnormality occurs in virtually every single individual with CF over the first 18 years of life. So if you follow their liver blood tests, I guarantee you every patient you follow as a pediatric patient before modulators is going to have abnormal liver blood tests. But 2 times the upper limit of normal and persistent is relatively rare, 5%. And if you look at the upper part, 3 times the upper limit of normal was really pretty unusual, except in the young kids. But even in the young kids, it didn't persist. We've looked at it in other ways. Nicole Meyer-Hamblett at the TDN looked at all of the control individuals in registry studies, and we found that the prevalence of abnormal liver blood tests was basically once every 2 years. And the more you tested, the more it happened. So these were individuals in control arms of safety studies getting lots of blood tests done. What's that sound like? What we're doing now. Well, that's all mainly pediatric data. What about adults? There'd been less attention paid to this, but I did find some data to share with you. And that both studies came from Canada. In a small study from Labrador and Newfoundland, the other side of the continent than we're on right now, in adults with CF, 57% of their adult patients had persistently abnormal liver blood tests for more than 6 months. And in Montreal, they were actually not looking for liver blood test abnormalities. They were looking for abnormalities in glucose metabolism, but they found that 39% of their patients had abnormal ALT. And it was actually more common in men and those who had diabetes. We also know that men have a higher risk, at least in other studies, of alcohol. So take it for what it is. Well, we're going to go to a primer on drug-induced liver injury. So this is probably the key question. How frequent is significant hepatotoxicity in CF with modulator therapy? So there are a variety of case studies. Most of these are all single center studies. So from Denmark, they used a cutoff, and everybody used a different cutoff, I'll say that too, of ALT or AST greater than 5 times the upper limit of normal and increased bili. In Denmark, it was about 1%. In Manchester, a really nice study by Daniel Tewksbury showed that it was about 5.6% that hit that. So that you're going to see it in your clinic. 8% were found to have severe hepatotoxicity in an Australian study, but only 1% ended up being long-term off meds. So something else is going on. Liver failure and transplantation, unfortunately, have both been reported, both with individuals who have advanced CF liver disease or advanced CF hepatobiliary involvement, but also in individuals with no evidence of underlying liver disease before they started. And upon close review, they did not have advanced liver disease. So very rare cases can occur with very severe outcomes. So my takeaway from this is that severe hepatotoxicity can occur, but it is rare. So let's take a step into DILI. This is the classic classification pattern. On the left, you have direct hepatotoxicity, which is really dose-dependent, very rapid. Think an acetaminophen overdose. Okay. Idiosyncratic hepatotoxicity seems to fit best for the description of CF liver disease, CF drug-induced liver injury. It's rare. It's variable, right? We see it happen over variable periods of time, and you have mixed patterns of this. And notice some of the drugs that are on this list. Some of these drugs our CF patients receive, like amoxicillin, clavulanic acid. It's idiosyncratic, and the mechanisms aren't well known. Well, why do I say it's not dose-dependent or drug-dependent? So I'm showing you data here that has never been shown before, and thanks to Vertex for actually allowing me to review this and show this. And I see all the cameras going up. So, so this is data from the elexacaftor, tezacaftor, ivacaftor treatment period in all of the pivotal trials and the open label run-on. And what they did is in those studies, they got PK exposure data. And what's described here is C trough. So it's not peak levels. It's not levels above EC50. It's peak trough. And the levels are just of elexacaftor, tezacaftor, ivacaftor, not of the metabolites. So I'm qualifying some of that. Then they looked in all of the individuals who had ALT and AST more than 3 times the upper limit of normal, and they looked at their C-troughs and put them into terciles, and to quartiles, sorry. And what you can see is the graph shows in the bar graphs the percent of individuals with ALT greater than 3 times the upper limit of normal that were in the various quartiles for C-trough. And you can see that it actually favors a lower C-trough. So although there's very clear reports of people doing better on lower dosing, these data don't support that this is a dose-dependent phenomena, at least based on the native compound drug levels. I think this is important as we think about this. It's trying to get at mechanisms. So I'm going to briefly talk about clinically significant issues, and that's, you may have heard of Hy's Law. Hy Zimmerman was a hepatologist back when I was a fellow. He was like 60, and he's now deceased, but he's the grandfather of drug-induced liver injury. And this value of 3 times the upper limit of normal in a bilirubin greater than 2 times the normal comes from Hy's observations that drugs that had that in their registry profile were more likely to cause severe hepatotoxicity in the future. But that's in diseases where there were not random elevations of transaminases. So you see a bunch of other other things here, and I'm not going to go through them all. But the FDA guidance really tells us that many drugs can cause elevated liver enzymes, but they may or may not go on to DILI. And Hy's Law hasn't held up quite as nicely as we'd like, but that's why the warnings are there. I prefer this approach to drug-induced liver injury. RUCAM is a scoring system that's been developed and modified by the Drug-Induced Liver Injury Network, and it classifies your liver injury as either hepatocellular, that means it's enzymes, or cholestatic or mixed, and that means you have bilirubin and GGT in that space. And you get various points for how fast did the elevation come on, and when you stop the drug, how fast does it go down, the overall course. Second thing I want you to come away with is liver tox. Liver tox is a reference through the NIH that has up to date, up until government shutdown, data on toxicity that's been reported for a myriad of drugs. It's the go-to reference, and these are not just drugs, but complementary alternative therapies, herbal teas, all of these things. So they also look to say if you have other drugs, which many of our patients that we care for do, you should look at those also. Are they likely candidates? Excluding other causes and additional data. The web link at the bottom is actually to a calculator that can do this all for you. I don't remember what it means. So I'm going to step to the last issue, which is the approach to elevated liver enzymes on modulators, something I was asked, really, thank you very much, to deal with. There's very little to no data on it. So from here on out, you're going to get personal opinion and approach. I'm just saying. So how do I think about this, and how have I done this as I go along? I think it's very important to understand the status of our patients going into therapy, or if they're on therapy now. Do they have no evidence of liver disease? Do they have evidence of CF hepatobiliary injury? And importantly, do they have advanced CF liver disease? How I think about abnormalities after that is important, and how you might dose. If there's a history of chronic elevation of liver enzymes prior to highly effective modulator therapy, do not assume that that is CF liver disease. We should appropriately evaluate that in partnership with your hepatologist for chronic hepatitis. And as I tell people, if you had a patient with chronic elevation of transaminases and a negative evaluation and they didn't have CF, what would you do next? Most of us would say we'd biopsy them. And so we ought to treat our patients just like we would treat someone else. If they have persistently elevated levels that are mildly elevated, you should probably use that as your baseline for 2 to 3 or 4 times the upper limit of normal. If acute evaluations occur, You need to develop a systematic approach to evaluating that in collaboration with your team. Standardized assessment for illness, drugs, alcohol, complementary and alternative medications. Follow them closely. I urge you to calculate RECAM, and if it meets your thresholds and decline rapidly if you discontinue, is more likely DILI. Well, how common are alternative causes? This study from Manchester, also Daniel Tewksbury, they found 19 individuals who had acute elevations, but when they went through this process, they only had 2 who had well-classified drug-induced liver injury. That means 17 had something else. And so if you ended their therapy based on that, you'd have 17 individuals who were missing this therapy. So back to the case. We evaluated her for other causes. They were all negative, except she had essential fatty acid deficiency. We treated that. Nothing changed. She had I'm aggressive. She had a liver biopsy 2 days after stopping, and RECAM was calculated. This is her liver biopsy. So for those who don't know, this is fat in the liver. She has lots of steatosis. There is some mild fibrosis, and there are eosinophils in the portal tract. This puts it in a risk range for drug-induced liver injury. We calculated her RECAM, and she came out to have probable DILI in that space. So she stayed off. We weren't going to put her back on. And so here's my last slide, which is a call to action. Develop standardized protocols with your CF team and hepatology. Classify your patients. Know what their liver involvement is. Be rigorous when you have elevated transaminases. Institute RECAM calculation. It's a website. Anyone can put it in. And then for the pharmacists in the room, please report drug-induced injury to the MedWatch. That's how we're going to know about this. We really need to develop a way to understand the mechanism of this, and that's going to take really well-defined individuals with drug-induced liver injury. And I thank you.
Take a couple of questions, and then we might do questions at the end. Come on.
The one caveat I'm going to say, I'm not going to answer any. I will answer offline, but I'm not going to answer any questions about individual patient management because that's not the role here today. Questions? See, I sat down because I knew there were none.
No. I guess I have one question I just thought about. Is it too soon to say whether there's going to be any notable difference with once daily, the newest highly effective modulator versus what we've been using for the first few years?
Yeah, so I'll restate it because he didn't use the mic. So do we expect differences with VTD compared to ETI? So in the registry studies, there was a slightly lower incidence of elevated liver enzymes, but they did occur. Okay. And I'm going to make a plug for a study. In the registry studies for VTD, any individual who was off ETI because of liver, they were not in that study because those studies required you to have an ETI run-in and then you got randomized to ETI or VTD. So people who had severe DILI were not in any of the registry studies. So that's a really important issue. If you got ETI, drug-induced toxicity, what's your risk with VTD? They're different drugs, but they're in the same class, but they are different. And so there is a study, and you heard about it yesterday at the plenary, called Retrial, looking at those individuals because we want to be sure that they don't have a 10 to 20-fold increased risk of recurrent DILI. Dan?
Yeah. Great talk, Mike. Thanks for getting us started. You showed that liver biopsy slide of that 12-year-old girl with steatosis of the liver. Can you kind of comment on whether or not you felt the steatosis was sort of present but unrelated to the moderate to severe hepatitis that you saw? You know, did she kind of meet criteria for pediatric MASLD or MASH, which is generally more portal inflammation, or did she not have any signs of MASH? Because we're in an era now where MASLD and MASH, at least in the non-CF patients, is now the primary indication for liver transplantation.
Right.
At least on the adult
in
side.
adults. Yeah. Good questions. First off, separating out steatosis from metabolic syndrome or other issues is very difficult from separating out from drug-induced liver injury, because you can get steatosis with drug-induced liver injury. This was bland, Dan, with no real inflammation around it. It looks like, and she was also lean. It looks like what I've seen a lot in lean CF individuals. The thing that shifted us towards drug-induced liver injury was the eosinophilic inflammation in the porta, and I think her steatosis may have been related partially to essential fatty acid deficiency, but it's actually persisted. Great.
All right. Up next is Dr. Amanda Fifi, who is an associate professor of pediatrics, formerly at the University of Miami. She was the director of pediatric nutrition at the University of Miami. There, she pioneered the first dedicated pediatric nutrition program. She's the author or involved in over 20 peer-reviewed publications. She's also a recipient of the CF Digest Award. And my friend, Dr. Amanda Fifi.
I go here. Okay. Hi. Good afternoon, everyone. I'm going to be talking about nutrition in CF, in cystic fibrosis associated liver disease. Sorry if I sound a little muffled or congested. I'm from Miami and my body does not function below 70 degrees at all. So I'm struggling, but, I don't have a goal slide, but I would say if I have one goal as the only nutrition person in a sea of liver people for this session, would be to convince you more on the importance of nutrition in the evolution of liver disease in our cystic fibrosis patients. So we know that people with cystic fibrosis are at higher risk for poor nutritional outcomes. We actually have a poster that we presented at this meeting where we showed the poor nutritional outcomes that persist in adult populations, with adult CF patients having higher rates of underweight than general population data. Also, in addition, we have improved life expectancy in our CF patients. And so we're going to see more and more of these more chronic diseases like liver disease in the future. It was something that we would probably all be faced with in our clinic to take care of a patient with CF liver disease. Depending on your source, CF liver disease affects about 15 to 30% of people with CF. The pathophysiology of CF liver disease is complex. They have multiple proposed mechanisms related to CFTR dysfunction, impaired bile flow, microbiota translocation, which is much better explained by much smarter people than me on this panel. But as you can see, these things are things that we know can also affect your nutrition, like microbiota abnormalities and impaired bile flow. Eventually, things like portal hypertension can develop, which can develop ascites, and which can also affect nutrition as well. There's several risk factors that are associated with the development of CF liver disease. We know severe mutations are more likely, meconium ileus, pancreatic insufficiency, so some nutrition again, the male sex, and potentially does poor nutrition actually assist in the evolution of CF liver disease as a whole. So we know that malnutrition and liver disease is a cycle. Poor nutritional status is a consequence, both a consequence and a contributor to disease in cystic fibrosis patients. There's several nutritional challenges that we face in CF liver disease. Of course, the degree of malnutrition varies. As you heard before, there's a lot of wide variation of liver abnormalities that you can see in CF. And the degree of malnutrition is going to vary based on the severity of liver disease. Patients with CF liver disease are going to struggle with issues with malabsorption, increased metabolic demands, hepatic complications like encephalopathy and stuff that might impair your intake, altered glucose metabolism, as well caused by decreased glycogen storage and liver malfunction. Malnutrition can be caused, first of all, by CF liver disease. So our patients with CF liver disease live in a cycle of inflammation and nutrient deficiency. Chronic systemic inflammation, which increases metabolic demands, leads to decreased intake of these patients. And also there are several mechanisms where they have impaired intestinal absorption. So you have decreased intake caused by things like encephalopathy and ascites, anorexia. Sometimes the diets aren't the most tasty, as we do salt restriction in some of these patients. But then also you have micronutrient deficiencies, the use of lactulose in patients with high ammonia, leading to dysbiosis that can affect the absorption in our CF liver patients, making their malnutrition then subsequently worse. The role of malnutrition in CF liver disease is an area that could be very ripe for research, because we do know that the CF liver disease is not caused by malnutrition, right? But in CF patients, we know they're inherently more malnourished, they're inherently at a higher risk of malnutrition. This malnutrition with micronutrient and macronutrient deficiencies have any role in increasing susceptibility or the actual evolution of liver disease in these already malnourished patients? There's limited data on this, and there's not many studies that look at the pre or peri-diagnostic nutritional status of patients when they're diagnosed with CF liver disease compared to patients who don't go on to develop CF liver disease. So one of the most obvious ways that you're going to get malnutrition in CF liver disease is, of course, fat malabsorption and bile stasis, which not only occurs just generally in CF patients, but worsened by CF liver disease. You have impaired bile flow, which worsens fat and fat-soluble vitamin absorption, leading to the obvious deficiencies that we all see and monitor in vitamins A, D, E, and K, which then goes on to exacerbate oxidative stress, contribute to hepatic injury, and can lead to coagulopathies and bone disease in our CF liver disease patients. Again, protein energy malnutrition is another big factor in CF liver disease, and that could lead to reduced hepatic. So the liver disease itself can lead to reduced hepatic protein synthesis. So of course you have less albumin, which we heard happens over a longer period of time, impaired production of clotting factors, muscle wasting that you could see, and poor growth, especially in children, with failure to thrive being one of an early sign of CF liver disease in some patients. Patients with sarcopenia have a poorer prognosis. So we know the patients that have poorer nutrition have shown to have a poorer prognosis in CF liver disease and in liver disease in general. Altogether, impaired protein synthesis can worsen portal hypertension and outcomes due to decreased oncrotic pressure. In addition, impaired protein metabolism in patients with elevated ammonia is another issue, because they're usually put on protein-restricted diets sometimes. We know that high ammonia levels increase inherent protein breakdown. We know that this high ammonia levels can also deplete your amino acid pool that's available for muscle protein synthesis, and so you have worsened protein breakdown. And now sometimes they're put on, maybe erroneously, on a low-protein diet, and then you're making this process actually worse, and you're making them more catabolic instead of improving their outcome. Malnutrition also worsens CF liver disease. So we know that CF liver disease worsens malnutrition, but malnutrition in and of itself can cause CF liver disease to progress more rapidly. So oxidative stress and CFTR dysfunction is a key driver in liver fibrosis, and is amplified by malnutrition. We know from several studies that vitamin E, selenium, and zinc levels have been shown to be lower in CF liver disease patients, and those antioxidant nutrients are active in liver repair and liver regeneration. Chronic undernutrition can actually accelerate your progression to fibrosis and then eventual cirrhosis, making it worse. So it's what we do know is that they go hand in hand, right? Malnutrition and CF liver disease. We have on one side, you have all the low nutrition that may occur in CF patients just in general, that are worsened by having liver disease with low zinc, selenium, your malabsorption of your macronutrients, vitamin deficiencies, then worsen on antioxidant functions. They live with systemic inflammation. This worsens your immune system, and then mitochondrial repair, which can then deplete the liver's ability to regenerate and for tissue repair within the liver, then therefore worsening the outcome. So is it like a chicken or an egg? Maybe not, right? So like which came first? I would like to inspire people to think, is it a chicken or egg? We know that for sure that the mechanism of CF liver disease, as explained by, the hepatologist here, is not caused by malnutrition specifically. It's not a malnutrition disease. But is there something within the malnutrition that's happening that's making some patients more susceptible? Do they have a micronutrient deficiency? Are they having things that are making them more susceptible to develop worsening liver disease or to, in the first place, develop liver disease? What we at least do know is that it's a vicious cycle of malnutrition and liver disease going around, and that we know that worsening liver disease worsens malnutrition, malnutrition worsens liver disease, and so we do have to find some way to intervene. On the flip side, which was touched on a little bit in the last talk, malnutrition, as I would call it, but many people call it overnutrition, is when you have, these high-fat, high-calorie diets that are common in CF management, lead to the potential for ectopic fat storage. So this is a little different this is not CF liver disease specifically, but this is CF liver disease that you might be asked, for people who are GIs here, you might be asked by your pulmonary team to see this patient. It might not be true, the same pathogenesis of CF liver disease, but this is something that you might commonly see. In fact, steatosis is one of the most common findings in CF patients. Up to 30% of patients, you're going to see steatosis on ultrasound more than other conditions. So sometimes the body composition of these patients might mask central adiposity and metabolic risk. We usually follow BMIs in our clinic. And CFTR modulators do improve GI function. They have been shown to be associated with weight gain. We do know that overweight is increasing in our CF population with changes in fat distribution, and there are emerging concerns for modulator-related metabolic effects. In addition, CF-related diabetes affects about 20-50% of adults with CF, and worsened insulin resistance, insulin deficiency can contribute to hepatic lipogenesis and fat accumulation in the liver that can present with these enzyme elevations or with these changes you might see in the liver. There was an Australian study that looked at CF liver disease and its relationship with CF related diabetes, and it showed that there was an increased incidence in CF related diabetes in patients with liver disease versus those without. So, again, going back to another shameless plug for the poster that we did, we show that overweight is actually increasing in our CF population, with numbers in some regions nearing that of the general population. This, steatosis was historically thought to just be a benign incidental finding. It may however, it may be mimicking MASL D and its pathogenesis and may be linked to other things like high-fat diets. The overlap with MASL D may represent a spectrum of disease, and there's, more and more to be found. Okay, so what do we do with these patients with CF liver disease? So the liver accounts for about 30% of your resting energy expenditure just in a regular healthy person, and it actually has increased metabolic demands in severe liver disease. So these patients actually require much higher energy levels than a typical patient. Of course, worsening based on the severity of their liver disease. So they traditionally require up to 120 to 150%. We know, from general studies, that up to 50% of patients with cirrhosis are underweight or malnourished, worsened in cholestatic patients. So this is going to be more for those type patients when you're seeing more advanced liver disease. But you would want to adjust, of course, for respiratory status, infection, overall clinical status. And so it is a dynamic thing where you're re-evaluating the patient to ensure that you're meeting nutritional goals. You're going to monitor their weight, trends, BMI, as we typically do in our clinic. Some of the macronutrient considerations, ones we already know, would be fat. You're going to use high-fat diets that are often used in CF in any case. Obviously, working with the pancreatic enzymes, and then you're monitoring for steatorrhea, adjusting the enzymes as appropriate to ensure that they have good fat absorption, which is going to give you the bulk of your calories in any diet. Protein, however, is a little bit different. We don't typically recommend high-protein diets in CF patients, but in liver dysfunction, you may require a high-protein diet, which is the alternative of what sometimes is done. Sometimes liver patients are protein restricted when, in fact, they actually may need more protein. And so they could require high levels up to 1.5 to 2 grams per kilo per day of protein. Carbohydrates, you want to monitor carbohydrate, glucose tolerance, of course, screen for diabetes as you would, and watch for insulin resistance in these patients. Some of the micronutrient considerations, again, very similar. The fat-soluble vitamins are going to be similar to your regular monitoring of your CF patients. Deficiencies are going to be more common in patients with EPI. But then in our liver patients, we heard earlier that the cholestasis is not super common in CF patients. In your cholestatic patients that have more advanced liver disease, you are going to pay more attention there to the fat-soluble vitamins, and they may require higher doses. These deficiencies will, again, impair antioxidant defenses and can worsen your progression of your liver disease. You're going to monitor the levels every 6 to 12 months, but that's, what we typically do. In some patients, you're going to need to do that more often. And the minerals, there's things that are a little special to liver disease that we might not be measuring in CF patients. So zinc, which is often low, magnesium, selenium, they could be low with liver impairment, and they have good antioxidant function. There have been studies that show that they are lower in patients with CF liver disease. And so supplementation of this could be appropriate, and this might be a change in practice that you would do because we're not typically measuring selenium levels in all our CF patients. Iron deficiency is important. We know CF patients are at risk for iron deficiency. About 30% of children with CF iron deficiency. Numbers can be even higher in adults. You want to distinguish anemia of chronic disease from iron deficiency and supplement and treat them as appropriate. Okay, so your nutritional assessment is not going to be that different than your nutritional assessment of any CF patient. We use the weight, height, length, BMI as usual. Remember that the BMI, as we talked about before, can mask metabolic complications caused by lean muscle D, as we say. Like sometimes you can have risk factors even with a BMI. We can also use, we talked about sarcopenia being a risk factor for worsened prognosis. So everybody laughs at me, but I use a lot of mid-arm circumference. I have my measuring tape, and people think that's hilarious that I come with a measuring tape, but that's a cheap, easy way to be able to monitor mid-arm circumference and look at muscle mass in a patient that might have ascites or something else in a severe liver disease, and you might not be able to tell based on weight only. Also skin fold thickness, I also love to do that as well, and that gives you an assessment of mass. The ESPEN actually recommends for CF patients that we start doing body composition measurements around 8 to 10 years of age. And they recommend things like DEXA, which, a little more fancy stuff that we may or may not have available. So that's something that you can consider in these patients as well. Some of the labs that you're going to do, you could use albumin and prealbumin with caveats. Obviously, they can give an idea of nutritional status, but they're not great. I'm not going to use the term liver function test ever again. I will scratch that off. So liver serum enzyme measurements and I copied this from somewhere. I didn't come up with that. Just kidding. Liver serum enzyme measurements and liver synthetic function measurements, as we do with with all our patients with CF. Of course, if you have abnormalities, you're going to monitor them more frequently. So everything is really personalized to the patient that is in front of you. Vitamin levels, again, monitored as usual, and then screen these patients for diabetes. The clinical signs you're going to look for is obviously in severe liver disease. In early liver disease, you see very limited clinical signs, which is why the guidelines came out that recommend lab tests and recommend ultrasound. But you can see, obviously, in severe liver disease, you may see jaundice, ascites, edema, muscle wasting. So when you're following these patients, you want to be aware of that. Hepatomegaly is actually the most frequent physical finding that you might see in CF liver disease. And so it's important that we always check the belly and make sure we're feeling for that. And then, of course, with our great dietitians that we work so closely with, we want to do a good dietary intake to be sure, because BMI doesn't tell the full story about what the patient's actually intaking and where there might be nutrition deficiencies. So doing a 3 to 7 day food recall, most parents are not going to do that. That's pretty difficult. But even a 24-hour recall can sometimes be helpful, just to give you an overall idea of, are they eating like chicken nuggets every single day, chips every day, or like, are they having more variety? And you could figure out where your risks might be. So nutritional interventions that we want to do in CF liver disease, the main take home is that early is better. The earlier you intervene, the better you're going to be, the better outcomes you're going to have. We know that early intervention leads to improved prognosis in terms of hospitalizations of patients with liver disease, in terms of overall morbidity. And then if they were, God forbid, to go on to a transplant, we know that definitely improved nutritional status pre-transplant improves outcomes post-transplant. So you're going to do some dietary counseling, but, also consider early enteral nutrition if that's what's needed. Consider nocturnal feeding tubes. Like, we shouldn't wait, which I know we all do. Sometimes, there's difficulty socially in convincing parents to do more, or adult patients. But the earlier the intervention, the more likely they are to have improvement in their outcomes. You want to obviously as well monitor for things like encephalopathy that may be altering their intake or their ability to intake. Use enteral nutrition as indicated, but in hospitalized patients, you might sometimes need parenteral nutrition. Supplements could be used, multivitamins, MCT oil, which is pretty good for cholestasis to give a good high calorie. And then sometimes you may need specialized formulas. Some special considerations for pediatrics, since that's what I do. So growth failure can be an early sign of CF liver disease. We want to do close monitoring of their growth velocity, and remember, do a good nutrition exam. Is something else that I get laughed at for talking about. But you want to expose them, do a real nutrition exam, not just using the weight. Look at the at the signs of muscle wasting, and look for signs of pubertal development, because sometimes you never get that growth back if you miss your opportunity. So we want to be sure that we're tackling nutrition early in our patients nearing puberty. There's supportive strategies that you can use, like calorie boosters. I'm a huge fan of all natural ways to give more calories. So I use a lot of oil, nut butters, avocado, like what high calorie things can we put in these for these patients? But sometimes, of course, you do need modular supplements. And if it's necessary, then of course, there are a lot available to prescribe it. You could also consider appetite stimulants in these patients as well, especially the ones that may have anorexia and cachexia developing from severe liver disease or chronic infections. Age-appropriate multivitamins should be used, and then obviously mineral supports. This is a multidisciplinary, it requires multidisciplinary management. It involves, of course, the CF dietitian working closely with a gastroenterologist and a hepatologist that's taking care of the liver disease, the CF care team, and then, but very importantly, social work, and to make sure that these families have the capability of meeting the needs, their nutritional needs once they do go home. We know that outpatient interventions early on can reduce the need for hospitalizations, and so making sure they have that support outpatient can be very helpful. And then, of course, you want regular case reviews. You're seeing them in the clinic. You might bring them back more frequently if they're showing signs of malnutrition with worsening liver disease, to monitor more frequently. And then the most important is a personalized care plan. Liver disease and CF is a spectrum, lots of different patients you're going to meet up with, and they require individualized care plan based on the severity of their own disease. Monitoring and follow-up is going to be weight and BMI, every clinic visit, fat-soluble vitamins every 6 to 12 months, liver synthetic function and liver enzymes, monitor their progression with your hepatologist, and then adjust your dietary plan based on severity and on the growth trends that you're seeing. A final thing on the emerging therapies and the impact of nutrition and CF liver disease. We know that emerging therapies are improving our nutritional outcomes. So we're seeing that, in real time. What we do not know as well, and there's more sparse data on, is how do they affect CF liver disease specifically, and how would that overall affect your outcomes? As was talked about before, these patients were omitted from a lot of the studies that involve these modulators, and so research is ongoing on their impact on how they will improve nutrition in CF liver disease patients, and so we stay tuned. So in summary, CF liver disease adds complexity to CF nutrition management. The goals are, of course, to maintain growth, frequent checks to correct deficiencies and support liver health. We want an individualized, dynamic, multidisciplinary approach with early identification. And then for me, a personalized intervention is key. It's not always a one-size-fits-all. I hope I've given you like a guide of the things you want to look for, but each approach is personalized because CF liver disease is such a spectrum for these patients. And that is it. I hope I covered everything, so you have no questions from me like before. Thank you.
Had one question from the web, Dr. Maria Mascarenas.
You're crazy.
Oh, no.
Yes.
What about monitoring essential fatty acid panels in chronic liver disease?
So I didn't see much on specifically, but of course you do want to imagine, I'm a big fan of essential fatty acid monitoring. Cholestatic patients could be more at risk. Of course, and a lot of my patients, I use MCT to try and make up the difference in calories, and it puts them at more risk for essential fatty acid deficiency. So it should be monitored. To say that there was like data on specifically when they should be monitored, how we follow it, I didn't find anything on that, but I monitor them in my own patients, and I do it with risk factors. So if I have a patient that's failure to thrive, having steatorrhea, like not growing as expected, I would more frequently. Or if I do that nifty dietary recall and I see that they're not getting much LCTs, they're not having much variations because they're on high MCT formula or something, I would also evaluate for that as well. Hi, thank you.
Hello, Jananne Stallings from CHOP. Two comments, and then I have a question about a nutrient you didn't bring up. So the energy expenditure, the energy requirements for CF are not that high. I know exactly where that quote up to 150% comes from, but our group had spent a lot of time doing energy expenditure, and the requirements are modestly elevated. I often say 10% or less, and the difference is a little less now on the new drugs. And in the old days, I'd say that's like eating a Snickers bar a day. I mean, it's not hard to overcome. So I don't want us to think that all of this is driven by excess energy expenditure. And on the intake side, almost all of the data where you have research quality dietary intake shows that our patients already take 1.5 to 2 times the protein requirement for someone else. So again, in these days where I feel like there's a lot of emphasis on pushing protein, we're starting off with a good protein intake, and then to add the pathophysiology stuff. The nutrient I think we should start to think about a bit is choline. And choline does have, an impact on fatty liver. In the U.S., almost all of us don't take in enough choline. In CF, we and others have shown that it's even lower, and that if you give choline, you can improve the liver choline status. The fat goes down, the choline comes up. And MRIs looking at the liver and the calf, a skeletal muscle. So that's completely treatable. And I think it's really been overlooked because, choline is an important part of the liver. And last, in therapy, there are some new products, and we could talk about it offline, that directly support the essential fatty acid and the choline needs that might be beneficial and are just becoming to be appreciated. But thank you for the overview. Looking at all the nutrition options is huge in the midst of CF plus end-stage liver disease.
Thank you. I think, just to add a comment, for the increased requirements, it may be like in CF liver disease, more advanced liver disease, that they may not be able to meet goals. So having, obviously it's personalized and you assess each patient differently as the disease progresses and becomes more severe.
Just to add,
Yeah.
the requirement is one thing.
Right.
It may be high or low, but the intake is also what you're talking
Right.
about. Their appetite goes down.
Right. Right. Yeah. Right. Exactly.
It's become more and more obvious in sarcopenia. It's an independent predictor of outcome in advanced liver disease. So in advanced CF liver disease, I'm really talking about portal hypertension. Right. What would you recommend for the teams for evaluation for sarcopenia?
Specifically, So, body composition scans, of course, could be used if you have that availability and you're able to do it. As I said, it is recommended to be started at about 8 to 10 years old now in patients. We can use more crassly, we could use skin pole thickness, use mid-arm circumference. That gives you just a more generalized, and over time, and there are growth charts specifically for predictable, to use predictions for mid-arm, upper arm circumference. So you can plot them if you Google some of your charts may have them, to plot to see how the patient's progressing, just to plot to see where they're meeting goals to address sarcopenia, and then being able to use, as I said before, some of these supplements to promote increased protein intake. And I think a lot of spreading the word of the misuse of protein restriction sometimes in patients with severe liver disease, especially when they have elevated ammonia levels, that sometimes overall worsens protein catabolism and actually makes them have worse outcomes instead of improving outcomes.
Just to add, I think there have been studies looking at MRI, iliopsoas muscle thickness to assess sarcopenia in patients with liver disease.
Okay, thank you very much.
Great. Thank you. Our next speaker is Dr. Jay Freeman. He is a professor of pediatrics at Ohio State University. He is the medical director of pancreatic care at the Pancreas and Liver Care Center at Nationwide Children's Hospital. He is the medical director of the islet cell transplant program at Nationwide Children's Hospital. He is a part of the CF Liver Disease Network. He's been a leader in the care of children with pancreatic disorders and GI and liver complications in cystic fibrosis. He's published multiple manuscripts, guidelines, position papers related to pancreatitis, constipation, and liver transplant in CF. So, Dr. Freeman.
Unlike Mike, I'm happy to take the applause before I talk, so that's fine with me. Thank you. Appreciate the invitation to talk today. I'll be reviewing liver imaging in people with cystic fibrosis. These are my disclosures. I will be talking about quite a bit of work that was sponsored by the CF Foundation and the NIH. None of the rest of this is pertinent. What I would say is pertinent is I am not a radiologist. So why am I giving the talk on liver imaging? Well, I think for me to get up here and tell you how to interpret the shades of gray would be the wrong thing to do. The goal of today's talk is really to take what the radiologist is giving us and how we're going to incorporate that into our screening and our monitoring of patients. Now, there's obviously a 50 Shades of Gray reference that should be done here, but I didn't want IT to take my computer, so I skipped that. Objectives is to review the importance of imaging and phenotyping and defining CF hepatobiliary involvement, or CF-HBI. We will discuss the various imaging modalities available for assessing CF-HBI, highlight that imaging alone is not adequate to characterize CF-HBI or advanced CF liver disease, or ACFLD. And again, going back to what I just said, the idea of this talk is to be clinically practical and hopefully help both the hepatologists in the room, but also the pulmonologists and those that don't have access to a hepatologist on how to take these new guidelines and use them in a meaningful way. So we just had lunch, we've heard lots of talks, the conference is going on, why am I going to do definitions and put you to sleep? I promise you I won't spend too much time here. But I was a part of the NASPGHAN Joint Committee position paper to really give a phenotypical characterization of CF-HBI. And obviously we've heard about liver enzymes, but right after liver enzymes we get right into the imaging of the liver. And this is to really start to get to whether we're normal, heterogeneous, homogeneous, or nodular. We're going to get into that a little bit more. After the liver imaging, we get into histology, but then you look at everything else, and it's all things that have to do with imaging. Stiffness of the liver is really going to be the elastography measurements, which we'll talk about. Portal hypertension is most likely going to be picked up by your Doppler on your ultrasound or by your MRI. Biliary is almost essentially MRI, and again, malignancies for our adult population. The one thing that you don't see on here is CT. So I'm not going to talk about it. We're going to talk a lot about ultrasound, elastography, and MRI. We also know that there's the new guidelines. They've been brought up quite a bit throughout the conference and during even today's session. And if we look at those, they're really broken down into screening, monitoring, and therapy. We're not going to talk about therapy, but if we look at screening, you obviously see ultrasound, elastography, and MRI jump off. They're very present in these recommendations. And if we look at monitoring, again, we see ultrasound, elastography. So really taken together, if you are trying to characterize or define or screen CF-HBI, you have to understand the imaging that goes along with it. And so that's really what we're going to focus on today. As a reminder, screening really should be non-invasive. There's similar versions of this in other manuscripts. This is one that we published together, but really we're going to focus on those indirect biomarkers, direct biomarkers from the labs. Dan's going to talk about that in a little bit, and then I'm going to focus on those ones below it, which is going to be our ultrasound, transient elastography, shear wave, and MRI. So why do we spend so much time talking about ultrasound? So this is probably the central finding from the PUSH study, which Mike led and we were lucky enough to be a part of. But if we look at these figures on the left, we look at over the 6 years from their baseline ultrasound and divide those patients that had either a normal or a heterogeneous pattern at baseline, and look at whether they went on to have nodular. Actually, this is the reverse. Those that did not go on to a nodular pattern. You see that over that 6-year period, you were much more likely, if you had a heterogeneous ultrasound pattern, to go on to develop a nodular pattern. Nodular being basically a surrogate here of advanced CF liver disease. Looking down here at the bottom, we also see that this mostly happens between that kind of preteen and teen years, which is really what we've seen in lots of other papers and articles. So how do we take these figures and put them into some numbers? Well, that's really what the table over here does. So combined, if you had a heterogeneous ultrasound, your relative risk for development of NOD was 9.5, okay? Now that sounds really high, and it is high, but does that mean that everybody that had a heterogeneous pattern is going to go on to have a nodular? Well, no, it's only about a third. So that's important to remember. We don't have to just tell our patients because you have a heterogeneous pattern that you're in danger. And more importantly, that normal scan seemed to be very protective of not going on to be nodular. And being able to tell your patients that you're safe is a good thing as well, instead of always having to look for what's dangerous or what's bad, right? So when we are using these terms, normal, heterogeneous, homogeneous, and nodular, what are we really talking about? So this is from one of the push papers. Normal up here, heterogeneous is this kind of speckled appearance. Homogeneous is this bright appearance, and nodular, you can see these contour changes. So just looking at this, I think it's not too hard to say that, you know, if you squint your eyes, maybe you see a little bit more speckle, you might get a little bit of variation between your radiologist. And so that's why we have this caveat with all of our studies that these were research ultrasounds. So every one of these ultrasounds from PUSH, and that I'm going to talk about in the remaining articles, these had at least 3 radiologists review. There had to be agreement between 2 of those 3 radiologists, and in many instances, we needed a 4th radiologist to break the tie. And believe it or not, there were scans that were read as normal and nodular. So there is a degree of variation in interpretation that has to be included in this, and especially when we put it into clinical practice, it's extremely important. So how can we do that? How can we limit that variation to the best of our ability? This looks like a very boring slide, but this may be the most important slide I'm going to talk about. So the recommendations say that the ultrasound that we get every 2 years should include the liver and spleen. For my practice, I make that also include the gallbladder and at least a single Doppler image of the portal vein. So first thing to do is to understand what the terminology is. Believe it or not, a limited ultrasound and an abdominal ultrasound are not the same thing. They're not the same thing at every institution. And believe it or not, sometimes depending on which radiologist you talk to, you might get a little bit different protocol. So it's important to understand what these terms mean at your institution. For our institution, they won't allow you to do a limited ultrasound as your first screen. They'll only let you get a full. So in order to get past that, we did something crazy. We went to that dark room and talked to our radiologist. And we made an order. It actually just went live. So now for a screening ultrasound, our patients get this, ultrasound abdomen limited CF screening. That way we get the liver, spleen, gallbladder, and a single portal vein image with Doppler to give us all that information that I'm looking for. And at most institutions, they'll do that single portal for little to no money. So again, the take-home point is go to that dark room and talk to your radiologist. After you get past that, then we start talking about how we're going to report it. How many of you have seen MRIs, ultrasounds, and depending on which radiologist reads it, it's a different template. It's a different dot phrase. So in addition to putting the order together, we now have a standardized phrase. Now, Mike did this at his group in Colorado and was nice enough to share this. We tweaked it just a little bit, but basically every radiologist that reads one of our ultrasounds are going to report it in the same way every time to try to help decrease that variation so that we can get a better idea of what's going on with our patients. So I just told you we don't have to tell all of our heterogeneous patients that, they're going on to nodular, but if they get to nodular, is it that bad? Do we need to freak out at that point? Well, this was a study here on the left with these violin plots that Simon Ling led within the PUSH network, where we looked at normal, which is kind of that teal, green and heterogeneous, nodular and purple, and homogeneous and red. And as you would expect, nodular patients had a higher ALT, GGT, lower platelets, higher spleen size Z-score, higher APRI, higher FIB4. For those that aren't hepatologists, the APRI and FIB4 equation is right here. But why they are abnormal and they're different, you can see that there's a lot of variation between here, okay? It's not like if you just have nodular, your platelets are going to be less than 50. Actually, on average, they're going to be normal. And so Dan, sitting here, actually led this paper that looked at over the 6-year period of those that had a nodular pattern, how many went on to have end organ sequelae or the really bad outcomes. So only 11% ended up having documented varices, with less than 4% actually going on to have bleeding complications, varicose bleeds, and the same 4% went on to have transplant. So again, just because we have a nodular pattern does not mean the end of the world. This is a sign that we have to watch these patients closely, and we have to have a monitoring plan for them. The other thing we need to be is consistent. Don't try to read the words. All right? There's a lot there. But again, this is thanks to Mike. He put this together where we have a verbiage that we can use to talk to our patients if we're uncomfortable talking about liver disease. This is now available on the MyCFF resource library. And so if you want to talk to your patients and tell them what their ultrasound means, or if it changed or didn't change, you actually have guidance based from experts in the CF Foundation so that you're able to deliver a consistent message and not scare the bejeebies out of your patients. So moving on to elastography, all right, again, anybody who's found to have CF-HBI should undergo a baseline elastography, and that goes on to talk specifically about transient elastography, i.e. FibroScan, shear wave elastography, you probably hear it called ARFI a lot, or MR elastography. They all have pros and cons. Transient and shear wave, very easy to do. Transient elastography takes less than 5 minutes to do at the bedside. Shear wave, it's just any B-mode ultrasound can do shear wave or ARFI. And MR is probably the best to give you the whole volume of the liver and the best overall assessment, but, you know, takes a lot longer. If they're young, they're going to need sedation. It has all its different complications. The other thing to remember is even with the transient elastography, when we talk about whether CF liver disease is a patchy disease or not, you get about a 200-fold increased sampling size by transient elastography than you do liver biopsy. So even though you can still get sampling error with these methods, not MRI, it is still actually better than your liver biopsy. So briefly talking about ARFI, or acoustic radiation force impulse. So remember when we were looking at elastography, to put it in really simple terms, it's how much does the liver wiggle, right? So if the liver's soft, healthy, you should have a fair amount of wiggle. That propagation should go through slowly. If it's stiff, that propagation should go fast and you get those higher levels. And so these are all the factors, including fibrosis, which is the thing we're probably looking for the most. But you can see there's a number of other factors here that can impact what our ARFI score is. Now, this table is busy, and I know that, but this is from that position paper that we did between NASPGHAN and ESPGHAN. And what I would really like for you to look at are these proposed cutoffs for CF liver and advanced CF liver. And there's not a ton with ARFI. There's a little bit less research, but you can see there's pretty decent variation. Usually it's going to be from the right lobe, but there's not a lot of consistency. And for advanced, you can actually see in this paper it's less than for regular CF liver disease. So it's a little bit of all over the place is my point here. And so I will just tell you at our center, if it's less than 1.3, I tell our families it's normal. We're not worried about it. And if it's over 1.3, we talk about if there's anything else we need to do differently with our monitoring or other imaging. We then get to transient elastography, or again, FibroScan. This has the added benefit of not only giving us a liver stiffness measure, which is shown in orange, but it also gives a CAP measure, which is a measure of steatosis, which we've heard a little bit about here in the blue. And if you haven't seen the FibroScan or used it, it literally just puts a little tap between the ribs, and again, it measures that propagation of that signal to give you an idea of stiffness. I was fortunate enough to lead the ELASTIC study, which is nested study within PUSH, and we were able to show that from our initial study with FibroScan, you did see that the nodular pattern was associated with a higher liver stiffness, and homogeneous, which we think of as being a marker of steatosis, was associated with higher CAP scores. Now again, going back to that idea of patchy nature of liver disease, we actually initially did this at 2 different sites and compared to whether there was a difference between the sites, and luckily we see pretty straight lines with our interclass coefficients super high, meaning that you really only need to measure at one site, and this was true for liver stiffness, a little bit more varied with CAP, but still with a very high ICC. So again, just one site seems to be good enough for transient elastography. Similar to what I showed you before, where again we're looking at cutoffs for CFLD versus advanced CFLD. You see within the CFLD levels as low as 5.5 and as high as 8.8. And again for advanced, as low as less than 8. Again, there's actual overlap, and as high as around 16. So again, from a practical standpoint, my interpretation is less than 5 is normal. Between 5 and about 8.5 is in the gray area, and anything over about 8.5, 8.7 is what the literature says, but 8.5 seems a little bit easier to remember to me. I think of that as being abnormal, and that's somebody that I'm definitely going to be getting an MRI on. For CAP, anything over 230 I consider consistent with steatosis. I'm going to share a little bit of something that we hope to be submitting next week, looking at longitudinal data from Elastic. And again, with that variation, what does that mean? So if we look to categorize these patients as low, moderate, or high risk, so for liver stiffness, less than 5, or again, that 8.7 cutoff, if you look at what their baseline FibroScan or TE, transient elastography, was, you see that it really goes all over the place. Patients with really high levels, some stayed high, some went low to the moderate, and some went all the way down to the very low risk. Very few from the low risk went high, and none all the way to the highest risk. So again, normal is really good. You can tell them that you should stay normal, or you don't have a lot to worry about. Those high levels still have to be interpreted with some caution, and quite frankly, the CAP stuff was a little bit of all over the place with lines going in all directions. The other thing you see with this variation is how much can you expect to change just from intra and inter-observer variation, and it's huge. So for any one of these measurements, the gray cone basically tells you what the expected variation would be, and that test still be within range or still be an appropriate test. And the big thing to note is as the values get higher, that range gets higher, which goes with what we think of clinically. If somebody says, oh, their FibroScan score went from 25 to 18, you don't care. That's still a really high number. So luckily there's a little bit less variation at these low ranges, but it's not nothing. And actually it may limit our ability to really use this modality to measure incremental progress. With that being said, this was a really cool study I came across out of Hungary where they used the Debré criteria as their definition and looked at a number of labs and imaging to see which was a strongly associated. So the bigger the blue circle, the stronger the association with the definition. And so here you see all the different lab markers and imaging, and the two that stand out for sure are transient elastography and APRI. If we look at just imaging, again, it's transient elastography over our ARFI. And then if we look at just our lab measures, it was APRI over anything else. This was just a comparison to their own definition, which really doesn't mean a whole lot for our talk. The other thing that came out that I saw recently was this was actually a study out of France that looked at the transient elastography intra-observer and inter-observer variation, again using that ICC measurement, and it's actually huge, 2, which is a very high number, compared to ARFI was 0.2. So again, even though there's a lot of data saying that transient elastography may be better, the variation makes it very hard to know what to do with it longitudinally. So again, there's pros and cons to both transient elastography and ARFI. You just need to understand what those are and how to use them to make clinical decision making. So that gets us into the MR elastography. Again, images from one of the PUSH studies. So we have an ultrasound up here on A that shows a little bit of a nodular contour. We have T1 weighted and T2 weighted MRIs. T1, fat bright, water dark. T2, it's the opposite, fat dark, water bright. All right. And then they're able to apply these masks in the red to get a volumetric of the liver and the spleen. And then they can draw areas to give us stiffness. And then this is actually hepatofat, and then protein density fat fraction to give us steatosis measurements. And we have shown that, again, as expected, the liver stiffness by MRE is associated with nodular ultrasounds, and our protein density fat fraction, our hepatofat, is associated with homogeneous. So that's not surprising, but I think this is where MRI can get really interesting. And so this was a study from the group from UT Southwestern. And so here in A, we have a patient with, again, kind of not the worst looking liver, but it's nodular, it's bumpy. We have actually esophageal varices seen here. And when we do the MRE, we see lots of red. So blue, purple, good, red, orange, bad, okay? This is a high elastography. So this is really suggestive of a cirrhotic, scarred liver with portal hypertension versus this liver that looks not quite as bad, but still bumpy and irregular. We actually see gastric varices here, but when we see the MRE, we actually show a very normal heat map. And so this is really more indicative of our portal obliterative venopathy that Dan's reported, or non-cirrhotic portal hypertension. So this may get to an idea of how we want to treat these patients a little bit different based on their imaging. And then I was asked to have a word on steatosis, so I will. You guys have seen these circles before. We know that things are going up. But, we used to tell everybody that, steatosis and CF was benign. So one thing that kind of got hidden in a lot of the push data is I think these homogeneous patients at baseline, of which there was 41, 3 or 7% actually went on to have a nodular pattern. So there probably is a small subset that has more mashal, phenotype than what we think of. So these patients can't just be ignored, and especially with what we're dealing with our modulators, we got to pay attention. And again, I know Dan's going to talk a little bit about this, but again, imaging is just one piece of the puzzle. So in PUSH, we showed that, our prediction for nodular was great using heterogeneous, but it went up when we used APRI. This was a paper that Grant Ram did with Peter Lewington and actually Dan as well, where they looked at liver biopsies and the association of liver stiffness and APRI, and why both performed pretty well. When you put them together, they did much better. This was an adult study that was done out of Manchester and then Edinburgh, where they looked at criteria for defining adult CF liver disease. And the take home here is it includes both imaging and labs. And then from the last PUSH paper that we put out, here's kind of a nomogram of how you can use ultrasound grade, age, and GGT to platelet ratio to get a score and get your risk of progression. So again, it goes to this idea, it's not just one thing, it's multiple things that predict risk. Don't read this slide. The point is, have a plan. All right. In my head, this is a little bit of what I have, maybe a little bit less on the elastography, but Dominique Debray put this out. It's wonderful. It gives you a nice algorithm. This group in Spain actually used a two-step and a one-step approach to see how to get there. For liver stiffness, they used something called HFS, which is includes a bunch of different labs and endocrine stuff, and then whether they were going to do VCTE or versus they just did VCTE by itself. And basically they showed with the one-step process, they actually captured more patients than a two-step process. And the same thing with the CAP scores is, again, using just the CAP from the FibroScan, they were able to capture all their patients that went on with MRE to have an over 5% fat fraction. If you like cutoffs, here you go. I don't. If you've ever heard me speak before, you know this is my soapbox. Trends. One snapshot in time is unlikely to give you the answer. We really have to be able to follow these patients. So my summary is imaging is a key component of screening, diagnosing, and monitoring, but it's certainly not all of it. It's just a component. Labs, history, physical exam, as we heard. And then, again, work with your radiologists. All right? I think it's such an integral part of this in your care team and develop a consistent plan. Thank you.
I have one question online that says, for peds, what about using the patient as their own control for liver elastography and monitoring the trend?
Yeah. So my guess is I got asked before, but absolutely, I think that's the key. I mean, even Mike said it about liver enzymes, right? If you're going to start talking about whether they're 2-3 times upper level of normal, let them be their own control. They don't necessarily need to start at 30 if they've been at 50 or 60 their whole life. So I think that's one of the nice things about the recommendations is we're going to have ultrasounds and we're going to have data early in their life to compare to, and we should be able to have longitudinal assessments with those trends that will be able to give us much better ideas on how to monitor and care for our patients.
At what point in these images would you recommend, if you're suspicious of non-cirrhotic portal hypertension, to do that HPV gradient testing?
Yeah, no, it's a great question. It hasn't changed a lot for me unless we're going to start talking about intervention. So if we are going to get to a point where we're talking about transplant or shunts and we want to really nail down, then we'll do it. If I'm still in the monitoring phase where I'm following labs, their platelets are fine, they're not dropping. And again, with platelets, it's a trend. It's not a raw number. You're going to see CF patients with a platelet of 100 that dropped, from 300. That should concern you more than the one who's, stays at 70 or 80. But if we get to that point where we're thinking about big interventions, that's when we're going to pull out the wedge pressures and we're going to get with IR and we're going to start doing some of that stuff.
Okay. I think in a lot of patients experience the hepatologists do not have experience with CF, and so they don't think to ask that or pursue that test. And luckily we did, and we were able to treat, and it's been helpful. So
No, and it raises an interesting question about transplant versus shunt in this population. Different centers take that task on differently, which that's not imaging, so I don't want to wade into waters I don't want to get into.
Hey Jay, Lauren Lazar from UT Southwestern and Children's Medical Center, Dallas. Great talk. I was just wondering, how are you using MRI, whether it's elastography or multiparametric MRI in your current algorithm in terms of, I guess, really monitoring liver manifestations in CF? I feel like at our center, we actually got MR elastography first, so we were pushing it a lot, and then as it became harder to get approved and we had ultrasound elastography more available, we've just been doing that a lot more. But now we're trying to figure out which patients do we feel strongly need MR.
So for me, I feel like I make a lot of families uncomfortable with high liver enzymes, irregular patterns, and I say, look, your labs look great, you're growing, like you don't have anything else. Right now we just have an imaging, or we have a single finding. And if that's all we have, then we hold off. If we start seeing any of those other things start coming into play, I start seeing platelets come down, I start seeing any of that other, then I have a very low threshold to get to the MRI. I've told a couple of people, I actually don't use transient elastography FibroScan that much. I was really big on it, but the CF clinic and the liver clinic are on the absolute opposite ends of the hospital, like probably a quarter mile away, and so I'd have to literally push the machine over to use it. And it's a $120,000 machine. They don't like that. So that's kind of come out of my algorithm so that I'm using the labs and the ARFI, even though I know the limitations of it, but that's what I'm following on a regular basis. If they come to me in liver clinic, then I'll get the FibroScan because I do like having the CAP score. But then as soon as I get to a point where I'm thinking this is something more than we can just monitor every 6 months, then I say we need the MRI and we need to have that baseline. Okay. Then I'm not trying to do that annually. Usually I'm doing something annually at least, but unless there's something that I'm really concerned about, I use more of my ultrasound.
So it's more of a tool and more of your advanced, or you think they may go to advanced?
Yep.
That makes sense.
Exactly.
Thank you.
Is there, when you get to the point, I have a few patients that are nodular livers, splenomegaly, CF, and they just stay there for years. Is there something on imaging that can tip you early or that correlates, or that's just not clear because...
Not that I'm aware of. I mean, I think we have these imaging findings that tell you your increased risk. I think most people know I transitioned about 3 years ago, and one of the first patients I picked up is exactly what you're talking about. Sweet little girl, she was probably about 11 or 12 at the time. She's got a little bit of a big spleen. Actually, her portal vein's a touch big. She got a nodular pattern. Her mom's asking me all the time, do I need to give her coffee? Do I need to give her sips of red wine? Do I need to do this supplement? And it's like, no. And over the last 3 years, like, nothing's changed. Yeah. Like her labs are the same. We've re-imaged her. Like, we haven't had to do anything. And every time we talk to her, it's the same conversation. Like, yes, you have risk factors. We're going to pay attention to them if this changes, and this is what we're going to do. But I'm okay letting somebody be okay. And I think that's sometimes a hard thing to do in CF, knowing that, we see these rates of decline in lung function and we hear these horror stories, but just kind of getting everybody to calm down sometimes and say, okay is okay, is actually one of the most meaningful things we can do sometimes.
Thank you.
All right, thank you.
Okay. Our next speaker is Dr. Daniel Leong. He's a professor of pediatrics at Baylor College of Medicine. He's the director of pediatric hepatology and liver transplant at Texas Children's Hospital. He is the director of viral hepatitis program at Texas Children's Hospital. He's very well recognized for his work on CF-related gastrointestinal and liver complications. He was actually the first digest group, and he has the expertise in validation of serum and imaging biomarkers of pediatric liver fibrosis to predict clinical outcomes in cystic fibrosis. He's been the PI and co-PI of multiple CF Foundation and NIH-funded projects, and he's also part of the CF Liver Disease Network. I actually went through your CV of like multiple publications, and there are more than 100 articles and book chapters that you've written. We look forward to your talk on fibrosis. Thank you.
Okay, well, thanks so much for hanging in there with us. This has just been a tremendous workshop. I have learned an incredible amount from my peers. I've been asked to speak about liver fibrosis in the context of CF liver disease. I don't have any disclosures related to today's topic. And during our short time together, I really want to reiterate why we use certain standard liver biochemistries that have now been recommended by the CF Foundation consensus, really to not only detect CF hepatobiliary involvement, which I will refer to as CF-HBI, but also early predictors of advanced CF liver disease or advanced CFLD. And then maybe in the second half of today's talk, I will sort of critically appraise the utility of some of these biomarkers or biomarker indices, not just to detect CF-HBI, but see if some of them can differentiate varying stages of fibrosis and again, detect early risk factors for advanced CF liver disease. So as mentioned, CF-HBI spans a very wide spectrum. We know what it is. It could be steatosis, it could be cholestasis, could be biliary abnormalities, but mostly abnormal labs. What it is not is advanced CF liver disease, which has been very nicely defined now by our CFF consensus recommendations group. Advanced CF liver disease includes one or more of the following. That is, do you have a nodular liver? Do you have severe F4 fibrosis on a liver biopsy? Or might you have imaging findings or clinical findings consistent with either cirrhosis or non-cirrhotic portal hypertension? And I think the field is really leaning towards trying to find a biomarker or a signature of biomarkers that may be early predictors of children who are at risk for developing advanced CFLD. Mike gave us a really nice tutorial about what all of these liver enzymes are, regardless of which theory you espouse to be causative of CF liver disease. I think the most important thing is that AST and ALT, again, are liberalized by hepatocytes, and GGT is primarily liberalized by the biliary epithelium. So pardon me if you see kind of a predominant focus on AST, ALT, and GGT, but these are standard of care biochemistries that you can order from any lab, and they are the components of the biomarker indices that I'm going to be sharing. So it's no surprise that our experts from the CFF consensus recommendations group suggest that we check these labs annually. And again, you'll see that these labs include total bilirubin, AST, ALT, alkaline phosphatase, GGT, and platelet count. I think one of the most important points, which I really appreciated from this recommendation, is that you should not be obtaining these liver labs in the setting of sickness, in the setting of a pulmonary exacerbation. If you can obtain these labs during a period of wellness, they may be much more meaningful. We know that inflammation and antibiotics can certainly confound your liver tests. Many groups have shown that standard liver biochemistries can actually be used as your biomarker. So AST, ALT, and GGT has been shown to predict the development of advanced CFLD. This was a nice study from Woodruff and Narkowitz at the Children's Hospital of Colorado years ago, which first showed that if you had an AST greater than 1.5 times the upper limit of normal, this was associated with a hazards ratio of over 6 of developing advanced CF liver disease. Similarly, if your GGT early on is ever greater than 1.5 times the upper limit of normal, this was associated with a hazard ratio of over 4 of developing advanced CFLD. Frank Baudet, our colleague from the Netherlands, was one of the first to show that the standard of care lab GGT may be quite different in patients who go on to develop advanced CFLD versus those who never do. Interestingly, he identified a threshold of a GGT value of 21 that may predict risk for advanced CF liver disease. And this is pretty remarkable because a GGT of 21 is completely normal. And I'm going to sort of dive into his work here in the next slide. Frank really believes that GGT may be a useful predictor of advanced CFLD, and I'm going to show you why. He determined that patients with CF who had a persistently high normal GGT value above 35, that these patients were found to have an odds ratio of 39 for a future diagnosis of cirrhosis within 2 years. This is pretty remarkable. And again, with just a threshold GGT of 21, this demonstrated an area under the curve of 0.9 to be able to detect advanced CF liver disease. We're going to switch gears a little bit. I feel like this liver test hasn't gotten much love during our discussion. We're going to talk a little bit about the platelet count, because I believe that this really is another important liver test, not a liver function test, but an important liver test for us to assess. If your platelet count is low, meaning greater than 150,000, your alarm bells should be ringing, and you should be trying to palpate for that spleen, because if you have thrombocytopenia, this may already be a sign of late portal hypertension. But as Jay mentioned, even if you have a normal but declining platelet count, say that again, even if your platelet count is normal but declining over a period of years, this may be a sign of emerging portal hypertension. So why is this? We know that fibrosis and congestion of the liver can cause a reversal of blood flow into your splenic vein. Obviously, your spleen can sequester platelets, and thus you get thrombocytopenia. 10 years ago, Laverdos presented this really, really cool work at a European CF meeting, and he demonstrated that in patients with advanced CFLD, these are really the only patients that ever develop platelet counts less than 150. So as you can see here in green in this Kaplan-Meier light curve, 73% of patients who were diagnosed with advanced CF liver disease developed a platelet count of less than 150,000, whereas less than 2% of the controls, shown here in blue, ever developed a platelet count that low, despite being followed for 10 years longer. This is work from the CFLD network, in which we showed that patients with a more severe liver ultrasound pattern, nodular, at baseline had a much lower platelet count than those with a normal ultrasound. And again, I'll just sort of point your attention to the fact that both values are within normal range. But when you look at the figure on the right, I think you'll appreciate the fact that patients with a nodular liver ultrasound have a very different trajectory. They have a much more rapid decline in their platelet count over time than those with a normal ultrasound. So I'm going to go to the next CF Foundation monitoring recommendation number 2, and that is if you are found to have CF hepatobiliary involvement, our expert group recommends that these patients have at least one liver fibrosis index calculated, and that this should be followed every year. So what are these liver biomarker indices, and why does this recommendation exist? These are the biomarker indices themselves. They include the AST to platelet ratio, otherwise known as APRI, Fibrosis-4, which I'll talk about less because the evidence in CF liver disease is not quite as strong, and then the GGT to platelet ratio, or GPR. These have been shown in liver biopsy validated studies to be able to discriminate varying degrees of liver fibrosis, as well as to be able to confidently detect CF-HBI, and they may be more specific than just your liver test alone. Why? Because they contain platelet count as one of the variables in the calculation, and I've shown you how platelet count may differentiate patients who are at higher risk for developing advanced CF liver disease. I should also mention that these calculators are often available online, and many of us have incorporated a APRI or GPR calculator into our electronic medical record. In one of the first, actually the first liver biopsy validated study of APRI and Fib4, this was just a wonderful collaboration with our colleagues in Australia. They are one of the few countries, one of the few cities in the world where liver biopsy, actually dual pass liver biopsy was considered standard of care in their patients as they evaluated for CF hepatobiliary involvement. And what we found is that APRI and FIB4, while both were better than chance at predicting CF-HBI, APRI demonstrated superiority with an area under the curve of 0.75. Similarly, we wanted to apply whether or not APRI and FIB4 was able to discriminate patients with severe fibrosis on liver biopsy, also known as F3 to F4, compared to those without fibrosis or mild fibrosis, F0 to F2. And again, APRI outperformed FIB4 and this time demonstrated an area under the curve of 0.81, which showed good discrimination. We wanted to determine whether or not any of these biomarkers may have clinical utility. How can we make this easy? How would a clinician even potentially use an APRI or FIB4? And based on the UDENS index, we determined that a cut point of APRI of 0.264 seemed to discriminate those with CF-HBI versus those who didn't. In fact, individuals with an APRI greater than 0.264 had an odds ratio of 6.4 higher of developing CF-HBI. Similarly, we again wanted to see if APRI could predict fibrosis and identified a cut point of 0.462, which conferred an odds ratio of 7 of having F3 to F4 or severe fibrosis. You can see here on the left that as the different fibrosis stages worsen, there's a general increased correlation with APRI, and we developed here some thresholds that were more highly predictive of the different fibrosis stages, and some of us do use this now in clinical practice. Years later, our colleagues in Australia said, can we do a similar study looking at the GGT platelet ratio? And given Dr. Beaudave's work more than a decade ago showing how sensitive GGT was, might GPR be even more helpful? And you can see here that patients with CF hepatobiliary involvement, we were able to discriminate these two groups with a GPR cutoff of 0.20 with an area under the curve of 0.81, just to be able to differentiate those with CF-HBI versus not. Similarly, we looked at GPR across the different fibrosis stages, and again, you can see increasing GPR in increasing fibrosis stage. This time, the threshold was a little bit higher at 0.32 to be able to discriminate those with mild fibrosis and higher to those with no to minimal fibrosis. And again, GPR demonstrated an area under the curve that was quite good with a value of 0.82. So again, very similar to APRI. And Jay showed this image already, but even though this is not a liver biopsy validated study, because Mike would never expose any of our study participants to liver biopsies, I think this study, for research, yes. I think this slide nicely shows that as your ultrasound pattern looks worse, normal is in blue, heterogeneous is in green, and then nodular in purple. First of all, you see this downward trend in platelet count. You see an upward trend in ALT and GGT, and even with the biomarkers, which are the newest kids on the block, APRI and FIB4, you see that those with a more severe liver ultrasound pattern have higher abnormalities. But not all biomarkers are created equal. Not all biomarkers that work in the field of adult hepatology are applicable to children, especially children with CF. And I think we need to recognize that because CF is a multi-organ disease, certain biomarkers may actually not hold up. And one of those tests was FibroTest. FibroTest is used in the adult world quite commonly in most hepatocellular diseases. There are 5 components to the FibroTest, each of which are independently associated with increased risk for hepatic fibrosis and hepatic inflammation. However, in this very, very nice study, they ended up finding that the diagnostic accuracy of FibroTest to delineate those who had CF-HBI was actually quite low, at only 64%. And why was that? One theory was when they looked closely at the different components of the fibro test, they found that haptoglobin very highly significantly correlated with CRP as an acute phase reactant. And as you can imagine, our patients with CF are in constant states of inflammation, whether that be in the lungs, whether that be in the biliary tree, whether that be in the gut, or whether that be in the pancreas. And so the thought was that because inflammation plays such an important role in patients with CF, this particular test was not able to really discriminate those who had fibrosis or not. And again, fibro test was quite suboptimal in underestimating fibrosis when compared to ultrasound elastography-based techniques. And then lastly, I didn't want to sort of glance over this because microRNAs are a very interesting group of biomarkers, but not so easy to obtain. Again, our colleagues from Australia, Grant Ram's group from the Hepatic Fibrosis Institute, reached out to collaborate on this. MicroRNAs, as many of you know, are these short interfering RNAs which can silence gene expression. So the idea is that if you can upregulate or downregulate them, might you be able to make some moves in the area of hepatic fibrosis? And that's because altered microRNA expression has, in many adult studies and pediatric liver diseases, been associated with a much greater fibrogenic response within the liver. So our hypothesis was, might there be some sort of microRNA signature that could differentiate those with CF-HBI versus not? And might there be a microRNA or two that might be able to show us progression of liver disease per liver biopsy? Now, when you look at this figure of relative serum microRNA expression levels, you're probably very unimpressed. The differences between those who had CFLD versus CF no liver disease versus non-CF controls are relatively subtle, at least visually. But I'll just sort of draw your attention to 3 microRNAs, which were highly statistically significant and had biology very, very relevant to hepatic fibrosis that our group decided to look into. They were hoping to develop some sort of model using some of these microRNAs to be able to predict CF-HBI with an even greater confidence than our biomarker indices. And here is that logistic regression model. They took those same 3 microRNAs, they put them into a very complicated regression model, and they added APRI, and they were able to generate an area under the curve of 0.9 to diagnose CF-HBI. But this is a lot of work to be able to detect CF-HBI and may not be practical. It's not quite as accessible. You're going to have a special lab. But very interestingly, they sort of drew our attention to a microRNA that was not included as part of that signature panel, miR-18A5P. And what they found is they were able to distinguish those with severe fibrosis versus little to no fibrosis with an area under the curve of 0.82. Many of you look at that number and say you could achieve the same thing with just APRI or FIB4. And so while very, very fascinating and perhaps very relevant to the pathogenesis of CF liver disease, microRNA is probably not ready for prime time in terms of being a useful clinical tool. So in conclusion, I hope I've imparted that a single blood test or biomarker is not yet superior to the others in detecting liver fibrosis and CF. Certainly not all biomarkers of liver fibrosis in the adult world are going to translate to pediatrics and specifically in the field of cystic fibrosis. Biomarkers for liver disease and CF really ought to be easily interpretable, validated either by biopsy or imaging, and accessible by all. And again, thresholds should be CF specific and thresholds should be monitored over time, not in isolation. And lastly, a combination of both standard of care blood work, biomarkers, imaging, and physical exam is really probably the best way to inform clinical decision making. Thank you very much. Happy to answer any questions.
So Dan, since ETI has come into existence, when you look across the studies, there's uniform reduction in platelet count across that. And we also have shown, and France showed and others showed, that GGT goes down. How are you thinking about these biomarkers in the setting of ETI, and do we have to re-examine their risk cutoffs, for example, because all of those were developed pre-ETI? Easy question.
Yeah. Thanks, Mike. I think that's a really important question that Promise and Begin has an opportunity to answer, right? Because part A of, I think each of those studies is natural history pre-ETI, at least in Begin it is. Yeah. And then part B, obviously, after exposure of ETI. Your point's well taken that a lot of these thresholds or biomarker cutoffs that we looked at in adolescent patients might not hold up quite as true in the younger patients. I think your data showed that even at a very young age, as early as 2 to 6, a meaningful portion of them had abnormal liver enzymes. And I'm going to be showing in our Begin data tomorrow that close to 50% of our very young children, unfortunately ages 2 to 5, had elevated AST, 25% had elevated ALT before even embarking on ETI treatment. So I think, to be determined, I think we should be excited that we may have a biomarker for ready application in adolescent patients and adults, but looking at the younger group of children, we may need to shift our paradigm a little bit.
I have 2 questions online. One is, when using liver indices such as APRI, is the upper limit of normal determined by the lab you are using or a standard number regardless of each lab's normal range?
Dr. Sellers in the back, do you want to answer that? Zach has really shown that choosing your upper limit of normal does matter, especially if you're using literature-supported cutoffs or thresholds. But I really liked what Jay said is, yes, the threshold might be important, but try to compare within the same patient over time using the same upper limit of normal. So that's my way of escaping the question a little bit. But I will say that in general, we have sort of adopted Jeffrey Schwimmer's NHANES, which was a national database of all U.S. children who were considered to be healthy and normal, that the upper limit of normal for AST and ALT, I think most of our pediatric hepatologists would agree, should be 26 or less. And then from many other studies, GGT of 20 or less. But again, I think it's debatable. I would caution moving the needle every time you get a different value based on the different lab value and using that as your upper limit of normal. I would be consistent in using the same upper limit of normal for the same patient over time.
I have another question. My hospital recently sold their outpatient labs to Quest, which uses 90 as their upper limit of normal for GGT. Are there any concerns about using such a high value for normal in calculating GPR? If so, what number would you recommend to be considered the upper limit of normal for GGT?
You're going to get me in so much trouble. Well, if you're colorblind and you can't see yellow and you can't see red, that's a problem, right? Especially if your upper limit of normal is 90. That concerns me. I think that's far too high. It obviously takes no consideration into patients with CF. I would say I have leaned, and this may sound overly conservative, but I have used Frank Baudet's cutoff of 35. It has been shown time and time again to be not the most sensitive marker, but a very specific marker. So I'm going to lean on that. Maybe a threshold of 35 is a fair number where you should start to worry about risk for advanced CF liver disease in the future. But please do not use that number to tell your patient you are going to have advanced CF liver disease, because it's still a very small minority of patients that ever develop advanced CF liver disease. But I think if your level is higher than 35, those patients need to be on notice.
You're talking about GGT, correct?
Yes, GGT.
Hi, Trey Tennant. I go to UMKC School of Medicine. Just had a question about your threshold values you had for 0.2 and 0.26 for the APRI and GPR. So in the 2024 paper, they had 0.545 as like the ACFLD diagnostic criterion, but you were talking about 0.2 and 0.26. Would that be more of like the CF-HBI and kind of that lower threshold maybe of, okay, we need to assess these kids more, maybe do a biopsy, or where did those numbers come from that you were talking about?
Yeah, great question, because those GPR values that I showed were liver biopsy validated, but they also used slightly different definitions for CF-HBI, and that may account for why that value is so much lower. But I wonder if others in the room who put together those guidelines could come up with, how did you come up with the 0.54, Mike?
All right. I'm getting tired of leaning over. So in the CFLD guidelines, Dan's data is the best data biopsy proven. The N's are relatively small in Dan's study. I was like 40 subjects, right, Dan? Something like that. So we combined that with some real world data looking like that Zach Sellers produced, where they had a standardized approach and used, didn't set the cutoffs until they'd actually evaluated everyone for screening. So we set them a little higher based on that data. So it's a combination of multiple data. The thresholds are really an area just to say you should take a closer look or you should not take a closer look. So that's really what they're designed for. And the 0.545 is more for more significant disease in that space. If you look at the push data, you can use GPR with the nomogram that Jay showed. And I do it all the time. I put it in. That may be actually a more valuable use for prediction of risk in kids, not in adults, because there were no adults in that study. So like Dan said, I think you use these to trend. You will notice, though, how many adult hepatologists do I have in the room? Oh, well. Okay, well, that tells us something. These cutoffs, so an APRI of 0.54 in adult world, they wouldn't even look at that. The APRI has got to be 1 or above to indicate significant fibrosis. So there's something different with CF liver disease and what it does. So again, and I am worried about the decline in platelet count that we're seeing overall. And Jay talked about the decline in the rate. Well, everyone's having a decline. So how do you determine what's too fast or not? So we're going to have to relearn that. But if you start using them, my experience is you're going to have people that come up and you're like, oh, I need to pay attention. But the reverse is if they're in the normal range, like Jay said, they're very unlikely to have significant disease. I don't know if that answered the question. But
Yeah, that was great. My only comment to add to that is platelets are an acute phase reactant, right? So almost all the time, if you're admitting a patient for a pulmonary exacerbation, don't be surprised to see a platelet count of 400, even if they have a spleen tip that is palpable. So that's my one word of caution. Yeah.
Yeah, I was just going to add to Mike's explanation. I think the other reason there's some differences between the numbers that we get, and it was brought up earlier, is that the upper limit of normals used to calculate those were slightly different between the papers. And so, it's important as you look at those recommendations, look in the footnotes as to what those were calculated based on, and whether or not you decide to use sort of those exact numbers as your upper limit of normal as you sort of track yours, just be cognizant of that. And if you end up using something slightly different, I think the advice given earlier is astute, that be consistent, right? Because if you're always changing those values, then your values are always going to change. And we had published a comparison study looking at that just changing that upper limit of threshold that you're using in the calculation severely changes those values. So be consistent. Know when you're looking at whether it's the guidelines or other people's papers that they're sort of publishing, what are the thresholds they're using, and then take that into consideration.
I have one question. Where do you place liver biopsy in the diagnostic algorithm? And the second part to the question is, when you have a young adult who's being evaluated for lung transplant, should this patient get a more detailed liver evaluation at the same time?
So first question is, where in the algorithm does liver biopsy lie? And I would say very rarely will you ever need to deploy that test. Why do I say that? I think in general, hepatologists are really good at excluding other causes of hepatitis, cholestasis, or cirrhosis, or portal hypertension, but certainly that has to be done. The only times that I have actually found a liver biopsy to be helpful, if I have a patient who has autoimmune markers that are elevated, if I have a patient with a family history of hepatitis B, hepatitis C, if I have a family history of alpha-1 antitrypsin deficiency, I'm probably going to get a liver biopsy because that's going to inform pathology of disease. Now, if those patients come to my clinic already cirrhotic with portal hypertension, I agree. A liver biopsy may be more academic at that point. But if you have a patient with CF liver disease and autoimmune hepatitis, your immunosuppression is going to be very different post-liver transplant than if they had no features of autoimmune hepatitis. And then what was the second question?
Lung transplant.
So if a patient is going for lung transplant, were you asking whether or not liver biopsy should be a specific part of the workup?
Yes. This is a young adult, so if we are already talking that they have progressive CF liver disease or may have liver disease, should this patient be evaluated?
Well, I think a liver biopsy may play a role, and we'll see if Jay agrees or disagrees. I think it may play a role if you are considering a portal systemic shunt. Are you going to shunt this patient because your adult has had 5 episodes of esophageal variceal hemorrhage, and with each time have a very high risk of mortality? And if so, then yes, perhaps shunt surgery may be very helpful. I don't know that you need liver biopsy, but liver biopsy is often paired with a hepatic venous pressure gradient. But again, you don't need a fancy HVPG test to diagnose portal hypertension. You have your hands and you have your labs.
So I wanted to add to the conversation. Mike's case was really intriguing to me because I had a very similar patient. And the data that he showed us from Vertex makes me feel better about my decision-making process. But I had a patient who really early when ETI was started, numbers went up, but probably had a pulmonary exacerbation or something, but things got stopped. Went on a lower dose, a modified dose. Numbers went up back and forth, but I just didn't get the sense that this was like really drug injury. And so we biopsied. And we actually saw very classic periportal fibrosis, no eosinophils, no plasma cells, no mixed cellular infiltration, nothing else. Looked like what you would expect for what we used to call CFLD, CF-HBI. And we actually put that patient on full modulator afterwards, and the liver numbers got better. So I think for me, when do you get liver biopsy? It's when you have a specific question that is going to potentially change your management, then that's the right time to do it. I'm not saying I was right. I could have been true and unrelated. But that's one of the times where I found it really helpful.
Yeah, thank you.
Hi, I'm Sarah Jane Schwarzenberg from the University of Minnesota, and I just want to add to the discussion of evaluation of a liver before a lung transplant. I think it's really critical that you be convinced that this patient is not going to have variceal hemorrhage after a lung transplant. This is the history of transplant for polycystic liver disease. The kids who had bad congenital hepatic fibrosis didn't die of the kidney transplant. They died of the hemorrhage afterwards. And now we are very cautious about evaluating those patients together before transplant. So I think you have to do whatever studies you need to do to be convinced that the venous pressure is low enough that if this patient goes into renal failure after their lung transplant, gets heparinized for dialysis, that they're not going to bleed to death on you. And sometimes that actually means a prophylactic shunt or even a transplant, a liver transplant, to ready the patient for the lung transplant, or done at the same time, depending upon your center.
I have one more question online. It says, do you think there is utility in doing formal testing for Gilbert syndrome in patients who developed unconjugated hyperbilirubinemia on ETI therapy? I recently sent testing and found a patient heterozygous for UGT1A1 decreased function allele. I have several patients with unconjugated hyperbilirubinemia after starting ETI whom we haven't tested for Gilbert's.
Yeah, I mean, depending on your literature reference, 3 to 7% of the population have Gilbert syndrome. So that's a pretty high incidence. So I personally do not lean heavily on enzymatic testing or genetic testing to make that diagnosis. Gilbert is a benign condition. It can be very distressing at times when a teenage boy shows up with icterus and jaundice during a period of catabolism. They just had a 2-day track meet, didn't hydrate well enough, didn't get good enough rest, and oh, by the way, Uncle Joe also gets yellow eyes when he gets stressed too, right? But it is a benign condition. So I think if you rule out hemolysis, you rule out a blood disorder to explain why your unconjugated bilirubin may be elevated, I think you're in the clear. Of course, your AST, your ALT, and GGT have to be normal in that setting to sort of clinically exclude Gilbert. But as it pertains to ETI, you're going to see elevations in unconjugated bilirubin by virtue of cytochrome P450 and how ETI works. And OATP, yes, thank you. But as long as you don't have coagulopathy, as long as your transaminases stay normal, I personally feel like it's very academic to get genetic or enzymatic testing.
Thank you. We've been on time for 30. Thank you very much. Thank you.